Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to the deep dive. Okay, picture this. A health issue so incredibly common that right now, almost 1 in 13 people around the world are dealing with it.
It's quite pervasive.
We're talking about low back pain, or LBP, and when we say LBP, we mean that pain in your lower back, basically from the bottom of your ribs down to your glutes.
Right.
And it has to last at least a day. It could feel like a dull ache, maybe a sharp pain, sometimes even a burning feeling.
Yeah, it varies a lot. Intermittent or just always there.
So our mission today, we really want to unpack this, cut through some of the common ideas, the myths maybe,
Usually lots of those.
and figure out why LBP is actually considered a major global health crisis. You probably think you know back pain, but I think there's more to the story here.
Oh, absolutely. And we should probably start with what's kind of the central paradox of LBP.
Paradox. Okay, I'm intrigued.
Yeah, so here's the thing. About 90% of all cases are what we call non-specific.
90%. Wow. What does non-specific mean exactly?
It means that, well, there isn't a clear disease or like specific structural problem, something you can easily point to on a scan that explains the pain.
Huh. So that kind of challenges the usual medical approach, right? Find the broken part, fix it.
Exactly. It immediately tells us we need a different way of thinking about it. We often call it the biopsychosocial framework.
Biopsychosocial. Okay, break that down.
It just means that your back pain isn't only about your body, your biology. It's this really complex experience that comes from how your body, your mind, your psychology, and your social situation, like your daily life and stresses, all interact.
That's a really powerful way to frame it right from the start. Because the numbers, when you look at them, they are just staggering.
You really are.
Since 1990, LBP has been the single biggest cause of something called years lived with disability, or YLDs, worldwide. And it still is.
Still number one.
And if you're wondering what YLDs are, it's basically a way to measure how many years someone lives with less than ideal health because of a condition, like time spent limited by it.
Yeah, it quantifies that functional loss.
Get this, in 2020 alone, LBP caused 69 million YLDs globally. 69 million.
It's hard to even grasp that scale.
It means no other health condition causes a greater loss of healthy, functional years of life. That fact alone should make everyone pay attention.
It absolutely should. And just to underline how common it is, in 2020, we estimate 619 million people were living with LBP globally.
619 million.
And the chance of experiencing it in your lifetime, even higher, maybe up to 85% of people will have it at some point.
85%, so most of us, basically.
Pretty much. And it's not going away. Based on population aging and growth, projections suggest that number could hit 843 million people by 2050. That's over a third increase.
Wow. So a huge growing problem. Now, I think a lot of people assume LBP is just something that happens when you get old. Is that right?
Well, that's a really common misconception. It's true that the rate of LBP increases with age, and it does peak in the, 80 to 89 group. But the largest number of people actually living with LBP, that's found in the 50 to 54 age group.
Interesting. So middle age is peak prevalence in terms of sheer numbers.
Exactly. And here's the really crucial part for society. About 70% of all those years lived with disability from LBP happened in the working age population, so people between 20 and 65.
70%. So it's hitting people right in their most productive years.
Precisely. It's not just an old person's problem. It's a major driver of lost productivity, economic strain. It impacts people during their prime working lives.
That really changes the perspective.
Yeah.
What about other demographic trends?
Well, one consistent finding across the board, different ages, different regions, is that LBP is more common in women than in men.
Okay.
And we do see regional differences. The highest rates tend to be in Central and Eastern Europe. Think Hungary, Czech Republic. The lowest rates are in places like Myanmar and the Maldives. But the overall patterns are pretty stable globally.
All right, so the scale is massive. It affects working age people heavily. But let's get into the why. This is where you said it gets really interesting, especially the non-specific part.
Yeah.
Maybe first, just briefly, remind us what the lower back actually is, structurally.
Sure. I mean, your lumbar spine, it's an amazing piece of engineering, really. You've got 5 quite large, strong vertebrae, the bones.
Okay.
Between them are the intervertebral discs, which are crucial shock absorbers. Then you have smaller joints called facet joints that help stabilize things. And it's all supported by a complex web of ligaments and strong muscles, like the big erector spinae muscles running up your back.
Got it. A complex system.
Very. And sometimes, in a minority of cases, we can pinpoint a specific problem there. That's specific LBP.
Like what kinds of things?
Things like a herniated disc pressing on a nerve, causing sciatica, that pain down the leg. Or spinal stenosis, which is a narrowing of the spinal canal.
Huh.
Or maybe certain degenerative conditions like spondylolisthesis, where one vertebra slips forward on another.
Okay, so those have clear, identifiable causes.
Right. But remember, that's the minority.
Minority. Because the real puzzle is the other 90%, the non-specific LBP.
Exactly. And here's the kicker. There's often this huge disconnect between what an X-ray or an MRI shows and what the person is actually feeling.
How so?
Well, lots of things we see on scans, like degenerative changes, disc bulges, they're incredibly common as people age. You see them frequently in people who have absolutely no pain at all.
So seeing something on a scan doesn't automatically mean it's the cause of the pain.
Precisely. It strongly suggests that the real problem for many people isn't necessarily the visible structure, but something less obvious maybe happening at a molecular or neurological level, the invisible biology, so to speak.
Okay, this is fascinating. So if it's not always the structure, what is going on biologically in non-specific LBP?
Well, research is pointing more and more towards molecular and nerve-related processes. Take the intervertebral disc, for instance. Even without a big injury, it can undergo changes over time. The internal matrix might break down a bit, might lose some water content, like wear and tear, but maybe more subtle.
Sort of, yeah. And these changes can sometimes trigger a local inflammatory response, even a low-grade one.
Inflammation, like swelling and irritation.
Kind of. We're talking about immune signaling proteins, cytokines, things like TNF-alpha, IL-1 beta, IL-6. These can become elevated locally.
Okay.
And these inflammatory chemicals, they can directly contribute to pain because they sensitize the nerve endings right there in your back. They make them more irritable.
Ah, okay. So the nerves themselves become more sensitive because of this low-level inflammation.
Exactly. And that leads us to nervous system sensitization. Think of it in two parts. First, peripheral sensitization.
Peripheral, meaning out in the body tissues.
Right. Those inflammatory chemicals lower the firing threshold of the nociceptors, the pain sensors. So they start sending pain signals in response to things that shouldn't normally hurt, like just moving around. The sensitivity dial gets turned up.
Okay, that makes sense. Things hurt more easily.
Then, and this is really key for chronic pain, there's central sensitization.
Central. So in the spinal cord and brain.
Yes. If the brain and spinal cord keep receiving persistent pain signals from the back, the central nervous system itself can become hyperexcitable. It learns to amplify the pain.
Learns to amplify it.
In a way, yes. It involves neurotransmitters like glutamate and substance P. It's like the volume control for pain gets stuck on high. This helps explain why chronic LBP can feel so intense, so widespread, and often seems way out of proportion to any visible tissue damage.
Wow. So the pain system itself can become the problem.
That's a good way to put it. It highlights that LBP is rarely just one thing. It's usually this complex interplay of factors, individual things, lifestyle, work, even psychological factors.
Right, that biopsychosocial model again. Let's dig into that web of risk factors. What contributes?
Okay, well, on the individual biological side, age definitely plays a part. That first major episode often hits between 30 and 50, and risk does tend to go up after that.
Genetics can be involved in some specific conditions, like certain inflammatory back diseases. And overall physical fitness is important. LBP is much more common if you're not physically fit, often because the core muscles supporting the spine are weaker.
Right, weak core is a common culprit you hear about.
Definitely. Then you have lifestyle and behavior. We mentioned those 3 big risk factors from the Global Burden of Disease study.
Yeah, the ones that account for nearly 40% of disability.
Exactly. First, weight and obesity. Just puts constant extra mechanical load on the lower back.
Makes sense.
Second, smoking.
You explain that messes with blood flow to the discs, maybe direct toxicity from nicotine.
Right. And third, insufficient sleep. Less than about 6.5 hours a night seems to be a risk factor, and it's often a two-way street. Pain disrupts sleep, poor sleep worsens pain.
A vicious cycle.
It really is. But the key public health point here, as you noted, is that these major risks, weight, smoking, sleep, they are largely modifiable.
Meaning we can do something about them.
Precisely. It's just a huge chunk of LBP disability is potentially preventable through proactive changes, both individually and maybe through population-level health initiatives.
That's huge.
Yeah.
Okay, beyond lifestyle, what about work? You said that was the single biggest cause of YLDs.
Yes, occupational and ergonomic factors are massive contributors. And it's a bit paradoxical because risk exists across a wide range of jobs.
How so?
Well, you've got the obvious ones. Physically demanding jobs with heavy lifting, pushing, pulling, lots of twisting or bending. Also, jobs of whole body vibration, like long-distance truck driving.
Okay, the heavy labor type jobs.
But then, on the other end, you have sedentary jobs. Prolonged sitting, especially if your posture isn't great or you don't have good lumbar support. That's also a significant risk factor.
So too much heavy work or too much sitting can both be bad.
Exactly. It highlights the importance of movement and proper posture regardless of the job type.
Okay. And the last piece of the puzzle, the psychosocial factors.
Yes, and these are incredibly important but sometimes get overlooked. There's a very strong, well-documented link between pain and mental health, particularly depression. It goes both ways.
How does that work?
Living with chronic pain is stressful. It disrupts sleep, can lead to feelings of hopelessness, all risk factors for depression. But also, depression itself can sometimes manifest physically as pain, and it can change how the brain processes pain signals, essentially lowering your pain threshold, making existing pain feel worse.
Another vicious cycle.
Definitely. And beyond depression, things like general anxiety, stress levels, and especially fear avoidance beliefs are critical.
Fear avoidance. What's that?
It's when someone starts avoiding movement or activity because they're afraid it will cause more pain or damage, even if that fear isn't entirely justified. This fear itself can lead to more disability. We often call these yellow flags psychological factors that predict a worse outcome.
So your mindset and beliefs about the pain really matter.
Hugely. And even broader things like socioeconomic status, income level, unemployment. These are also linked to worse outcomes, showing that social context plays a role too.
Man, it really is a complex web. Okay, so given all this complexity, how do we navigate treatment? You mentioned a big gap between guidelines and practice.
Yes, that's a central issue. Ideally, there are structured clinical pathways, but the first step in diagnosis isn't usually about finding the exact anatomical source for non-specific pain.
Right, because often you can't.
Exactly. The main goal is triage. We need to place the patient into one of three broad categories.
Which are?
1, non-specific LBP, which is the vast majority. 2, LBP with nerve root involvement like sciatica or spinal stenosis symptoms. 3, LBP where we suspect a serious underlying cause, what we call red flag.
Red flags,
Yeah.
like warning signs.
Precisely. Screening for these is critical. It helps identify that small minority who do need urgent investigation. Things like a history of major trauma, a history of cancer, unexplained weight loss, fever, chills, loss of bowel or bladder control, or severe worsening neurological problems like foot drop.
Okay, so ruling out the serious stuff first is key.
Absolutely paramount.
Now, for that huge group with non-specific LBP, let's bust a myth. You hear about people getting x-rays or MRIs right away.
Yes.
Is that generally recommended?
No, absolutely not. For nonspecific LBP, especially in the first, say, 6 weeks, routine imaging is strongly discouraged by virtually all major clinical guidelines.
Strongly discouraged. Why? It seems intuitive to want to see what's wrong.
It does, but the evidence is clear. For most people, it doesn't actually improve outcomes. They don't get better faster or have less pain because they got an early scan.
Okay.
Plus, it significantly drives up healthcare costs, exposes people to unnecessary radiation with x-rays and CTs, and it can actually cause harm, what we call iatrogenic harm.
Harm from the medical process itself.
Because, as we discussed, scans often show incidental findings, normal age-related changes that aren't actually causing the pain. But when a patient sees a report mentioning degenerative disc disease or a bulge, even if it's minor and common.
Sounds scary.
Exactly. It can increase fear, anxiety, make them afraid to move, and lead them down a path of seeking more tests, more interventions, maybe even injections or surgery, all based on a finding that wasn't the real problem. It fuels this cycle of medicalization.
That's a really critical point. So if routine scans are out for most people initially, what should be the first line of attack? What does the evidence support?
It really starts with education and self-management.
Okay, like what?
Reassuring people that acute LBP usually has a very good prognosis. Most cases get better on their own. Advising them to stay active, continue normal activities as much as they can tolerate.
So not bed rest. That used to be common advice.
Definitely not bed rest. That's strongly discouraged now. Activity is key. Then we look at physical and manual therapies. Things like applying superficial heat can feel good. Spinal manipulation, often done by chiropractors or physical therapists, has evidence. Massage can also be helpful.
Okay, staying active, maybe some hands-on therapy. What about exercise specifically?
Exercise is fundamental. There's broad agreement. It's beneficial for all stages of LBP, acute and chronic. For chronic LBP, specific approaches like exercises to strengthen the trunk muscles, aerobic conditioning, and motor control exercises are really well supported for reducing pain and improving function. It's about empowering movement.
What about approaches like acupuncture or yoga? Do they fit in?
Yes, for chronic LBP, there's growing evidence for some complementary approaches. Acupuncture seems likely to help with pain and function in the short term. Yoga has shown medium to large effects for reducing pain and improving function. Again, usually short-term benefits studied.
If those don't work.
For more complex, chronic cases that haven't responded well, multidisciplinary rehab programs are recommended. That involves a whole team, doctors, physios, psychologists, maybe occupational therapists working together.
Okay, so lots of non-drug, non-surgical options first. When do medications or surgery come into play?
They generally should be reserved for specific situations, definitely not the first step for non-specific LBP.
So if someone needs medication,
If medication is considered appropriate, the first choice is usually a non-steroidal anti-inflammatory drug, an NSAID, or possibly a skeletal muscle relaxant for a short period.
what about common painkillers like Tylenol? Acetaminophen.
Interestingly, the evidence suggests acetaminophen is actually not effective for low back pain.
Really? That's surprising. It's so common.
It is. And opioids, they should absolutely be a last resort. Only considered for severe pain that hasn't responded to anything else and used with extreme caution because the risks are substantial addiction side effects.
The very limited role for opioids. What about surgery?
Surgery is needed for only a very, very small percentage of people with LDP.
Who are those people?
Typically, it's for those specific pathologies we mentioned earlier, like severe spinal stenosis causing significant limitations, or a herniated disc with worsening nerve damage, or that rare emergency called cauda equina syndrome. And even then, it's usually considered only after a thorough trial of comprehensive non-surgical management hasn't worked.
So surgery is really the exception, not the rule.
Very much the exception for back pain overall.
It really sounds like the main problem isn't a lack of good treatments, but getting the right treatments to the right people at the right time. That evidence practice gap you mentioned.
That is arguably the biggest challenge. The overuse of things that aren't first-line routine imaging, opioids, injections, premature surgery, it drives costs up, doesn't improve outcomes for most, and can even make things worse by promoting chronicity. Closing that gap is paramount.
Okay, so let's talk about the broader impact then. What is the true price of all this pain beyond the individual suffering?
The toll is immense, both economically and psychologically.
Let's start with the economics. How much does LBP cost society?
It's staggering. In the U.S. alone, the total annual cost is estimated to be well over $100 billion.
$100 billion a year.
Yes. The direct healthcare costs, doctor visits, medications, therapies, imaging, surgery are huge, maybe around $86 billion annually. That makes LBP the third highest category of healthcare spending in the U.S.
Third highest. Wow.
But here's the thing. Those direct costs, they're actually overshadowed by the indirect costs.
Indirect costs, like what?
Primarily lost wages and reduced productivity from people being unable to work or working less effectively because of their pain. These indirect costs make up maybe 2/3 of the total economic burden.
So the impact on work is even bigger than the medical bills.
Far bigger. We're talking somewhere between 83 million and potentially over 180 million lost workdays in the U.S. every single year just due to LBP.
That's incredible.
And interestingly, a relatively small group of patients with very chronic disabling LBP, probably fewer than 5% of all cases, they account for a massive chunk, maybe 75% of all those costs.
So a small group drives most of the expense.
Which tells us that preventing chronicity is key, not just for individuals, but for the economy, too.
Okay, that's the economic side. What about the psychological toll? You mentioned the pain-depression link earlier.
Yes, that pain-depression cycle is incredibly powerful and well-established. Living with constant pain is distressing. It messes up your sleep. It can make you feel hopeless. all of which increases the risk of depression.
And depression can worsen pain, you say.
Exactly. Depression can actually manifest physically as pain, and it changes how your brain processes pain signals, making you more sensitive. It creates this really difficult downward spiral.
Are there other psychological factors involved?
Definitely. Anxiety, general life stress, and those fear avoidance beliefs we talked about, being afraid to move, are also critical. These yellow flags are often better predictors of who develops long-term disability than the physical findings on an MRI scan.
So how someone copes mentally and emotionally is hugely important for their outcome.
Absolutely crucial.
Okay, this paints a pretty stark picture of the burden. It really underscores why prevention has to be a major focus. We need to stop people getting to that chronic stage or even having the first episode, if possible.
Exactly. Prevention is key. And we can think about primary prevention, avoiding that first episode.
What works for primary prevention?
The single most effective strategy we know of: exercise.
Just general exercise.
Well, studies show it can reduce the risk of a new LBP episode by about 33%. The best programs seem to combine core strengthening exercises with either stretching or aerobic exercise, doing this maybe 2 or 3 times a week.
So strengthening that natural brace for the spine.
Precisely. Strong core, better posture, less risk. Education is also helpful, especially when combined with exercise. It can cut risk by around 27%.
Education about what?
About the fact that most LBP isn't dangerous, understanding good body mechanics, knowing it's okay to move.
Right, fighting some of that fear.
Yes. And then there's ergonomics and body mechanics, adapting your environment and how you move.
Like at work.
Yeah, redesigning workstations, using lifting aids if needed, and training on safe lifting. Bend the knees and hips, keep the back straight, hold things close.
Practical, Chase.
Very practical. And the key takeaway here is that prevention is active. The things that work require you to participate, to change behavior. Passive things, like just wearing a back belt at work all the time, the evidence doesn't really support that for prevention.
Interesting. So you have to be actively involved in preventing it. What about stopping it from coming back or becoming chronic? Secondary prevention.
That's where addressing those psychosocial factors early becomes really important. Screening for yellow flags, those unhelpful beliefs, fear, low mood.
So you can intervene sooner.
Right, with things like cognitive behavioral therapy or other approaches to help people manage their thoughts and emotions about the pain, and crucially, avoiding over-medicalization.
Like we talked about, not doing unnecessary scans, avoiding bed rest, being super cautious with opioids.
Exactly, sticking to the guidelines that promote activity and self-management, rather than interventions that might unintentionally foster fear and disability.
Okay, so pulling this all together, this deep dive really hammers home that LBP is, without a doubt, the world's biggest cause of disability.
Unequivocally.
And for most people, it's nonspecific, which means just looking for a broken part, that old biomedical model, it's just inadequate.
It really is.
The real burden is functional, what people can't do, and economic and psychological. So prevention and restoring function, not just stopping pain, have to be the goals.
Absolutely.
And we have good evidence for conservative non-drug approaches, but the massive challenge is actually getting that evidence put into practice consistently.
That's the crux of it, bridging that gap.
It really makes you realize LBP isn't just about bones and discs. It's so much more complex.
It truly is. You could call it a socially complex, wicked problem. There's no single, simple solution. It needs an integrated response across different sectors.
What would that look like? What are the future directions?
Well, we definitely need more high-quality research, especially in lower and middle-income countries where the burden is huge but data is often lacking. And more research into those molecular and neurological mechanisms could open doors for new approaches down the line.
Okay, more research. What else?
We need real reforms in clinical practice, promoting team-based, multidisciplinary care for complex cases, better education for both doctors and patients so everyone understands the evidence and moves away from harmful myths.
Changing mindsets.
Yes, and that extends to public health and policy. Maybe public campaigns to shift societal beliefs about back pain, that it's okay to move, that scans aren't always needed, championing evidence-based ergonomic standards in workplaces, and importantly, reforming how healthcare is paid for to incentivize high-value evidence-based care instead of just rewarding more procedures.
So a multi-pronged approach is needed. Research, practice change, policy shifts.
Exactly. It requires tackling it from all angles.
Well, this has been incredibly insightful. So as we wrap up, maybe a final thought for you, the listener. What stands out to you from this deep dive? Perhaps it's this idea that tackling a condition affecting almost everyone isn't about finding one magic bullet fix. Maybe it's about understanding this intricate dance between our minds, our bodies, and our environment. And maybe the power to prevent a lot of this suffering lies more in our everyday choices, our activity levels, our stress management than we ever really thought possible.
Concierge Care, providing world-class, personalized care for patients and members, taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.